Hi, everyone, and welcome to the Innovations in Family Planning Advocacy during COVID-19 panel session titled Advocates Look Forward: What Will Ensure Family Planning Continuity in the Year Ahead? My name is Kate Barrett, and I am a Program Officer with Advanced Family Planning at the Johns Hopkins School of Public Health. We are excited to bring you this panel that highlights examples from across the globe of how advocates are responding to the challenges of continuing family planning services during COVID-19. The panel highlights innovative advocacy responses and adaptations to ensure family planning continuity during the pandemic. I would now like to introduce you to the moderator for this session. Siva Tanandran is the Executive Director of the Asia Pacific Resource and Research Center for Women, or ARROW, a regional partnership organization which works across 15 priority countries in Asia Pacific and with regional organizations and networks across the Global South. Siva's different career choices, which included teaching, writing, commercial publishing, communications, and working at the UN, gave her opportunities to explore many work disciplines and form her ideals of working in partnerships and respecting diversity. She is the lead conceptualizer of ARROW's Reclaiming and Redefining Rights, which monitored the progress of SRHR across 5 regions of the Global South, and is the lead author of the Asia Pacific Report. She writes and advocates extensively on sexual and reproductive rights. Thank you, and welcome, Siva.
Thank you, Kate. COVID-19 posed serious challenges for all of us working in the field of sexual and reproductive health and rights. Firstly, what was evident was in the way in which health systems and personnel were deployed to combat the virus, and of course, to handle one of the largest health crises we have ever witnessed in our lifetimes. In order to concentrate on battling the pandemic, health administrators divided health services into essential and non-essential, with many services such as family planning, access to safe abortion services deemed as non-essential services. These moves then denied and delayed essential services to women and young people. Lockdown, also imposed at country level, saw NGO service providers having to shut down their services because NGO service providers are the ones often offering subsidized services to poorer communities and safe spaces for young people, and this also delayed and denied services to these very vulnerable groups. In a number of key countries, it took a few months to get these SRH services recognized as essential services and to be rolled out. Unfortunately, not consistently across the board for all countries. And in a number of countries, we are still seeing that services are not available. Our ability as civil society to conduct effective advocacy and to hold governments accountable also was reduced. If we had in the past grumbled about shrinking civil space, this space became almost non-existent in some circumstances at certain points. We were now entering into the second year of the pandemic, and we are seeing simultaneously both vaccine rollout, and yet we are also seeing mutations of the virus. Numbers are soaring across almost all continents. So it is timely for us to look back and learn from key advocates and in the field about where the innovations in services and innovations in advocacy are occurring, and how these advocates have been able to overcome some of these insurmountable challenges, and how we can help shape the SRHR advocacy agenda with governments and ensure that these essential services, essential to us anyway, are actually being received by women and young people. Our first panelist is Bridget Kazebu. Bridget is a youth advocacy associate for the International Youth Alliance for Family Planning under the Empowering Evidence-Driven Advocacy Project in Uganda. She has also been part of the Population Reference Bureau's research process and formulation of the outcome of advocacy products. Bridget was part of the World COVID-19 Youth Task Force, which held discussions and formulated creative ways to promote youth access to SRHR information and services during the pandemic. Her family planning mantra is, "Do not give up on family planning before you find the method that works for you." Her presentation is on using technology platforms to promote youth-led accountability by mapping contraceptive methods and service availability in Kampala, Uganda. We know that access to contraceptive services amongst youth was already a challenge in Uganda, and COVID-19 worsened the situation. As a result, youth leaders have been at the forefront of the advocacy and accountability efforts during the pandemic. Bridget is here to share the work of the International Youth Alliance for Family Planning members in Kampala.
Thank you, Siva. Hello to everyone. My name is Bridget Kezabu, an advocacy associate for International Youth Alliance for Family Planning. And my presentation is titled Using Technology Platforms to Promote Youth-Led Accountability, Mapping Contraceptive Methods and Service Availability in Kampala, Uganda. Yes, so like I said, I'm representing International Youth Alliance for Family Planning in Uganda. And what do we do? Our mission is to advance sexual and reproductive health rights and justice for all young people to achieve an equitable reality by having young people take the helm. Yes, so I'll give a background to our innovation back here in Uganda. Our innovation is called the Contraceptive Google Map, and it is a map that is focusing on Kawempe division in Uganda, Kampala in particular. So the background for this innovation, it started when there was a research carried out in 2018. This research was supported by Population Reference Bureau and International Youth Alliance for Family Planning. This research was done in 3 districts, that is Kampala, Mayuge, and Kabale. However, our innovation is a solution to the Kampala research data that was collected. Focus groups and interviews were carried out in Kampala, and the findings revealed that youth-friendly contraceptive services were not readily available. If I'm to say more about that, we realized from the research, because the research was around what limitations do young people face as they try to access contraceptives. And in Kampala in particular, one of the issues the young people brought up was that they do not know where to go to access the contraceptives. Fine, they see health facilities around Kampala, but they don't know which one in particular will offer the contraceptives to young people. The second issue is that the times when they decide to walk into a health facility, they probably have a preferred method. But when they reach the facility, the preferred method is out of stock and not available. So that alone is discouraging, and the young person ends up giving up on looking for a contraceptive. So I'll go to the next slide and talk about our innovation towards those issues. Yes, like I said, our innovation is called the Contraceptive Google Map. So the Contraceptive Google Map is an online platform. It's accessed using a browser, and it's a platform which any young person who has access to a laptop or to a mobile phone, basically a gadget, and has some internet data, this young person can be able to type in a link and be able to see the map. So the map is able to give information on 7 health facilities in Kawempe division. One, through the map, you're able to see where it's located, if it's operating, and which contraceptives are available in real time. So on our end, we interact with these health facilities and find out which contraceptives do they have available. So we keep updating this map in real time so that by the time the young person is looking at the map, they're able to see that this facility has this contraceptive, this facility does not have this contraceptive at this particular time. So this helps the young person to plan and to not waste time. I mean, they'll just easily go to the map, see the facility, see which contraceptive they are interested in, and then decide. So that in that case, they just move directly to the facility without wasting time and without getting discouraged and finding when the contraceptive is not available. Let me just show you how the map works. So like I said, you go to your browser, you type in www.prb.org/Kawempe map. Yes, so after clicking that, typing in that link, the map will appear. If you notice, the map will have plus signs. The plus signs represent the health facilities. Click on any of the plus signs. If you click on the plus sign, you'll be able to see that our health facility appears. You'll see a list of methods and services that are offered under that facility. Then if you click on another plus sign, you'll see another health facility, also displaying the methods available and the services available. So each time you click on those facilities, you'll be able to see, for example, if you're interested in the implant and you probably go to a particular health facility and they don't have the implant, you can try another facility and know which facility is able to provide your preferred method. And this was our solution to the issue of young people reaching health facilities and finding their preferred method not available. Yes, so what is our progress and what are our successes? So far, as we've been running this Google Map for a year, and I would like to say that we've had over 5,000 users so far. We've also had positive testimonies from young people who have benefited from using the map. They have shared with us how the map has eased their access to contraceptives. And like you can see from the slide, that was one of the testimonies from one of the young people we interacted with, who was able to access their contraceptive of their choice from Komamboga Health Center, and they were not disappointed. Yes, we also have a video that displays and talks more about this advocacy innovation. And this video is on YouTube on the Population Reference Bureau YouTube page. We also collect, like I said, we keep on updating this map. So we have to do bi-monthly meetups with the health facilities in order to know what contraceptives are in stock and which ones are not available, which services are available, just to keep our map updated for the young people to access. And then we also share data, key data, and policy commitments related to youth and reproductive health. So each time we collect this data, we are able to have it summed up in one folder, and we're able to share it with key policy makers, for example, the Ministry of Health, and also the health facilities themselves, so they're able to see the trend of their contraceptives in terms of the stock and consumption rates and availability. Yes, so our next steps, we want to use this data that we collect each month. However much this data is helping us to update our map, we also want to utilize this data and be able to share it more with the suppliers. In Uganda, in particular, we have national medical stores and joint medical stores who supply contraceptives to health facilities. However, these are all managed by the Ministry of Health. So we want to have a partnership with Ministry of Health where our data feeds into their decisions. Our data is able to guide them on what to supply to particular health facilities. For example, if a particular health facility, the clients that go to that facility probably ask for a lot of injections, that means that facility needs stock of injections more than probably the other methods. So we want to use our data to be able to guide the suppliers to supply the right methods to these health facilities. In that case, we shall be able to address the continued challenge of stockouts at these facilities. And also in future, this particular model and this innovation can be replicated in other countries. Thank you very much.
Our second presenter is Rafia Rauf, who is the National Coordinator for the White Ribbon Alliance Pakistan. Rafia is an experienced professional with a demonstrated history of working in Pakistan's development sector. Her career spans over 17 plus years, during which she has worked in the areas of project designing and implementation, grants management, organizational evaluation, and change management. She also possesses strong analytical skills and excellent reporting and documentation skills. She has had first-hand experience of working with the government as well as with international donor organizations. Rafia's presentation is titled Ask, Listen, Act, Elevating Women and Their Demands in Family Planning, Budget and Policy Advocacy in the Sindh province of Pakistan. Decision makers are ultimately accountable to women, girls, and beneficiaries with their family planning, budgets, and policies. Yet there are few opportunities for women and girls to systematically inform these processes. Understanding women's needs and calls for family planning takes on greater urgency during the COVID-19 pandemic, when many governments are redirecting resources away from family planning and reproductive health. Rafia shares the experiences in the Sindh province of Pakistan and how the White Ribbon Alliance and partner organizations pioneered novel advocacy approaches during these times to precisely do this.
Thank you, Siva, for the introduction, and hello, everyone. Before I start the presentation, I want to start with a very brief background. At White Ribbon Alliance Pakistan, our work on family planning is based on the premises that women and girls as primary users of family planning services should not be considered as passive recipient of these services, but rather as right holders with distinct needs and preferences, and that their engagement should be central to the rollout of all FP initiatives in the country. In line with this, my presentation today will be focusing on two novel advocacy interventions undertaken by our organization in the province of Sindh, Pakistan, during the time of COVID to provide an opportunity to women to inform the family planning decision-making process in the province of Sindh. We will all remember 2020 as the year of the COVID. This year was challenging for all, but for women, it was especially more so. First of all, because the availability of services of reproductive health and family planning was severely compromised. And secondly, looking at governments' shifting priorities and their interest in addressing the pandemic, there was a very strong likelihood that the funds allocated for reproductive health and family planning would be diverted towards addressing the pandemic. So, how did we respond to it? Cognizant of the situation, we decided to take concrete evidence gathered in the form of women voices and take that to the policy makers of the province with the objective of influencing their program and resource decisions. So how did we go about that? I'm sure that most of you must be aware that in the year 2018, White Ribbon Alliance undertook a global campaign called What Women Want. We, as members of the Alliance, also undertook this campaign in Pakistan. And in Pakistan, under this campaign, we reached out to 250,000 women from across the country. And we asked all of them one question. So what exactly is your topmost need regarding your reproductive and maternal health? Now, the answers that we got were varied and very interesting. And interestingly, family planning came out in the top 10 key asks. Now, family planning was a demand of women from across the country. However, since we are focusing on Sindh, so our first priority was to find out as to what exactly do the women of Sindh want in terms of family planning. So what we did was we went over their data, their statements, and we did a very in-depth qualitative analysis of those statements. And we found that women of Sindh basically wanted four things in terms of family planning. They wanted information about methods so that they could make informed choices. They wanted services to be free and to be in their vicinity. They wanted health workers and health facilities to be made available to them. And they, of course, wanted better quality of services. Now, what did we do with all this analysis? We took this to the movers and shakers of the Sindh province, the decision makers. First of all, we undertook a series of one-to-one meetings with the Costed Implementation Plan Secretariat. Now, the CIP Secretariat, which is housed in the Population Welfare Department of the Government of Sindh, is the primary body at the provincial level for not only ensuring implementation of the Sindh FP 2020 Task Force recommendations, but also for making the plan for Government of Sindh's FP 2030 targets, that is for the next 5 to 10 years. So this was the right body to talk to. Following that, we conducted a series of virtual consultative sessions with non-government FP experts and also with relevant departments and programs of Sindh. Now, the timing of this exercise was very important. The budget was set to be announced in June. So we had this 2 to 3 months advocacy window of opportunity, to take our analysis forward and convince the decision makers. Well, our strategy worked. Voices of women are very powerful, and we were able to actually lead to a 5% increase in overall budget for family planning measures in the government of Sindh's budget for the financial year 2020-2021. Now, this was a big achievement. However, our work was not done. So we moved on to the next advocacy intervention, and that was the designing and implementation of listening sessions. So what exactly are these listening sessions? These listening sessions were carried out in 5 districts of Sindh. And the basic objective behind these sessions was to provide a platform where women from the community would be able to engage with the district level decision makers, managers, to inform them about their FP needs with the objective that these gaps could be identified and addressed. Now, considering the COVID-related protocols and obviously the social cultural sensitivity that is involved in discussing a subject like family planning, we divided this session into 2 sub-sessions. In the first one, we gathered 15 women. And by the way, these were the women who had earlier participated in the What Women Want campaign. So we brought them, we sat with them, we discussed their family planning problems with them, and most importantly, we asked them for solutions to those problems. And then the next session, we took these suggestions and the demands and the suggestions to the district level managers. And we informed them about the women voices. In this, you can see some pictures from our listening sessions. On the left side, you can see pictures from our first session in which the women were discussing their family planning needs and giving some solutions. And on the right side, you can see the pictures of our second subsession in which we took those demands to the district managers. The important thing was that on the second session, we took a very vocal and confident woman with us to act as spokesperson. So while we were there, she was definitely there acting as a spokesperson for all the women. So what did these listening sessions actually achieve? What we witnessed was that women voices acted as a catalyst of change at the district level, while at the same time identifying some very important policy priorities at the provincial level. Soon after these listening sessions, we witnessed changes in the district level. For instance, we witnessed that pictorial messages started being used for meeting information needs of illiterate women. We noticed that the existing forum of lady health workers monthly meeting started to be used for conducting refresher trainings in client counseling and interpersonal communication as required by the women. We also noticed that the issues regarding regular and timely follow-up of FP clients was resolved simply by sensitizing medical superintendents and officers in health facilities. And we witnessed an improved coordination at district level between the offices of health and population welfare and other development partners in better execution of different activities like better coordinated family planning camps and provision of FP commodities. At the same time, these women highlighted some very important priorities at the policy level. For instance, providing specific medicines, increasing geographical coverage of services, and allocating additional and specialized providers. So, looking at the success, the efficiency, the efficacy of these listening sessions, the government of Sindh has decided to include listening sessions in the upcoming PC1. This document will be the primary investment of the government of Sindh for achieving its FP 2030 targets set forth for the coming years. In this way, for the first time in Pakistan, our government has included any citizen-driven accountability process in FP services delivery. And after this, women will be regularly and directly involved in routine process of the government for the purposes of accountability and improvement. Now, this was really a big achievement. So basically, through these small and strategic measures, we at White Ribbon Alliance Pakistan were able to elevate women and their voices and use that as a lever for influencing and informing the family planning decision-making process in the province of Sindh, Pakistan. Thank you so much.
Our third presenter is Ida Ndion, Senior Program Officer at PATH. Ida leads the work on self-care for sexual and reproductive health, as well as non-communicable diseases at PATH in Senegal. She provides technical support for the Ministry of Health's Maternal and Child Health Division in convening the Self-Care Pioneers Group and developing national self-care guidelines. Prior to this role, Ida served as PART's monitoring and evaluation coordinator for the introduction of subcutaneous DMPA and provided support on research and institutional communications. Ida has over 10 years of experience working at the intersection of public health, sociology, and health policy and financing. She holds a master's degrees in health promotion and social development, as well as the anthropology of health. Ida's presentation is titled The Right Issue at the Right Time, Advancing Self-Care in Senegal During the COVID-19. And she shares with us how COVID-19 has highlighted the importance of advocating for and enabling women to manage their own reproductive health, especially in a crisis when health systems are at their weakest through self-care approaches.
Merci, Siva, et bonjour à tous.
Thank you, Siva. So, my name is Ida Indion. I'm in charge of the PATH group in Senegal. It is present in numerous countries. So we work on sexual and reproductive health. So we believe that women and girls should be able to make their own choices concerning their health. So to that end, we work closely with partners and also with the government in order to advance care. We seek to improve access to health and products, and also to promote women's empowerment. We also try to create an environment that's favorable to care, and we work together with authorities in supporting initiatives to advance self-care. So what is self-care? So there's many different ideas about that, but for those who don't know what it is, here's a definition that was given by the World Health Organization. Self-care is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. That is the definition that has been given by the WHO. In addition, it also makes it possible to make products available to women and to make available anything that can help with self-care. So we do awareness raising among the community members so that they can access health care and also increase their engagement and improve their access to health care. So in the healthcare system, there are different ways to access these services, and the goal is for self-care to exist on a continuum of interventions in the healthcare system. So there are initial interactions that occur in connecting with healthcare services. So with service providers, so that the healthcare system can provide products and self-care practices. So self-care is really based on a healthcare system that's resilient and that is also reactive. So what are the opportunities and challenges for self-care in Senegal? So after the WHO published its first guidelines on self-care, particularly reproductive and sexual health in 2019, a world movement came into being to ensure that countries could integrate self-care policies. So we identified an opportunity therein for Senegal. And the government showed leadership by promoting self-injection, which is something that already existed in Senegal. So this intervention has also been recommended for self-care. So although self-care is a relatively new concept, these interventions have existed for quite some time. And part of the awareness raising consists of recognizing that there already are interventions and that some people already use self-care through various services or service centers. So we've been able to implement that and also to have the Ministry of Health implement self-care regimens. So we want to have this implemented between the government and various partners, and that's why we've given communities in the healthcare system means in order to be able to have a more formal environment so that they can practice self-care in a safe and effective way. So our advocacy efforts for self-care began at the beginning of 2020. And that's when the first cases of COVID were identified in Senegal. So the arrival of the pandemic put the brakes on this initiative, but because we were able to adapt our strategy, the pandemic situation actually gave new momentum to self-care strategies in order to be a way of responding to COVID. So it was a form of new visibility for self-care. So our first objective was to increase awareness and advocacy and to train self-care advocates and also to identify the role that they could play during the pandemic. So we first organized a symposium an awareness-raising symposium in March, and we put forward the various programs that already existed, and we also had a representative of the World Health Organization come to talk about health guidelines in order to support this self-care initiative. And we had an initial commitment made by the Minister of Health. This event was planned, but as the pandemic progressed, we adjusted our priorities in order to be able to respond to the needs of the Ministry of Health. The ministry set forth its idea of considering self-care to be a response strategy to the pandemic. So a group was created, a limited group, following a group was created following this initial symposium. There was a limited group that was created consisting of symposium participants who met virtually in May in order to identify national priorities concerning advocacy and response. So we set up this worldwide group for promoting self-care and also the White Ribbon Alliance, the Self-Care Trailblazer group. The White Ribbon Alliance on behalf of the Self-Care Trailblazer Group, developed this leveraged global advocacy roadmap for self-care. So the participants recognized the importance of creating a national group in order to think about this issue. So regarding the launching of the Senegal Self-Care Pioneers Group, on July 24th was International Self-Care Day, and Senegal launched the Self-Care Pioneers Group. And under the leadership of the family planning group. So it's interesting to note that among this group, all of the actors were brought together, and it was also interesting to do this work. It's something that reflects the realities of Senegal. So concretely, what happened is that Senegal was in a good position already with regard to this issue because it had a strategy on self-injection. So it was an interesting opportunity to create a link between self-care and self-injection. There was already follow-up being done on that, and an agency was created. So self-care was an opportunity to create a response and to support a strategy for a contingency plan to respond to COVID. So what was really interesting here was to be able to share the home care strategy in order to be better focused on serious cases of COVID, while also promoting self-injection services. So what we've learned from this initiative is that there's been a certain number of lessons. So first of all, we saw the importance of adapting the message to the context of Senegal. So self-care is a very valuable tool in responding to COVID, and the ministry has true commitment to this. It's important to understand that this commitment allows us to move forward. So self-injection services that have been provided have also been strengthened for the different service providers. And we have a very broad group that goes beyond reproductive health to talk about communicable diseases. And to provide various self-care services in that regard. For example, the use of insulin therapy. And guidelines will also be adapted, and that's also important in terms of lessons learned. So what's next on the horizon in terms of self-care in Senegal? Well, it's an initiative we're very proud of, that it involves the participation of various players, both at the national and international levels, with the participation of PSI, the Self-Care Trailblazer Group, which are important partners, but we could also mention at the local level a local partner, PRE, and each of these partners took the initiative to take a lead on an activity with healthcare service providers, including the owners of private clinics and private associations and civil society, and associations of patients and women, religious leaders, and associations of young people have all been participants and are stakeholders in this initiative. There's also mapping of the different stakeholders that has been carried out. So I will conclude here. Thank you very much for your attention.
Our last presentation is from Sarah Baum. Sarah Baum is an associate at IBIS Reproductive Health, where she leads a portfolio of social science research addressing access to safe abortion and reproductive health care. As an expert in qualitative methods, Sarah prioritizes developing research questions in partnership with clinic and advocacy partners to gain a deeper understanding of preferences, priorities, and experiences of people seeking and obtaining abortion and contraception. She has published and presented on work assessing abortion-related stigma and quality care among providers and women, evaluating uses of medication abortion in legally restrictive settings through various modes of service delivery, and documenting the impact of restrictive abortion and family planning laws. Sarah holds a Master's of Public Health in Reproductive and Family Health from Columbia University's Mailman School. Sarah's presentation is entitled Partnerships in Research and Advocacy to Advance Access to Contraception and Abortion During and After COVID-19. In this presentation, she talks about the amazing partnerships that IBIS was part of in order to advance interventions on self-managed contraception, emergency contraception, and abortion, and what we need to jointly advocate in light of an ongoing pandemic.
It's great to virtually join ICFP and my fellow presenters today. My name is Sarah Baum, and I'm a researcher with IBIS Reproductive Health, an NGO committed to conducting rigorous research addressing sexual and reproductive health around the globe. We have offices in the US and South Africa, and I'm talking to you today from California in the US. I'm going to share with you partnerships in research and advocacy to advance access to contraception and abortion during and after COVID-19. IBIS conducts rigorous research in partnership with a range of stakeholders, including community-based groups, clinics, activists, and advocates. We aim for each of these collaborations to center respect, mutual accountability, and shared power. We believe that research is going to be most meaningful if the questions we ask are developed jointly with community partners, and if the research findings are relevant and useful not only for policymakers and advocates, but for the community themselves. We have seen how research can contribute to the expansion of evidence-based advocacy efforts. And as we all know, it's been particularly important during COVID-19 to document people's experiences accessing contraception and abortion, as well as assess the challenges and successes of SRH advocacy efforts that are more critical now than ever before. So today I will share two examples. The first is accompaniment support for self-managed abortion. And just so we all have shared definitions, we define a self-managed abortion as whenever an individual takes mifepristone and misoprostol or misoprostol alone outside of a clinic setting without any supervision from a medical provider. They still might interact with the formal healthcare system, but they primarily manage the abortion process themselves. Safe abortion hotlines and accompaniment models operate in 40 countries, often run by feminist organizations and collectives, and work primarily in restrictive settings. They provide people with step-by-step information on how to safely use abortion pills, possible warning signs, how to assess completion, and strategies for safely interacting with the formal system in the event that they need to. The counselors are with people either in person, by phone, or other smartphone apps throughout their abortion. The accompaniment groups have had to make various changes during COVID-19. They've had to adjust to social distancing and lockdown requirements that impact how they can interact with their colleagues, as well as the people that they're supporting. These include smaller operational changes, such as creating a web-based phone so that they don't have to exchange an actual phone or go into the office, and bigger changes, such as moving their group counseling sessions from in-person to Zoom. The accompaniers and counselors have also had to adapt information they provide because people are navigating increased barriers during the pandemic. This might include clinic and pharmacy closures, higher medication prices, and stockouts. One strategy has been to expand their network of allied pharmacists and providers in order to refer when necessary. In terms of research, over the past 6 months, we conducted interviews with 7 accompaniment groups in Africa, Asia, and Latin America to document these changes during the pandemic. One thing noted in these interviews, the counselors noticed trends in their callers. They believe that they've seen more calls from young people, more cases of domestic violence, and more financial instability. We also conducted interviews with callers in partnership with 3 hotlines to gain a deeper understanding of their abortion experience during COVID and find out how the pandemic played a role in their decision to have an abortion and presented barriers or facilitators to care. We're in the process of conducting analysis on these interviews with clients, and we'll bring the results back to activists to inform further changes. The second example of advocacy changes during COVID-19 that I want to share is the Free the Pill campaign based in the United States. This campaign has worked for years to build support for moving the birth control pill over the counter. Many countries are ahead of the US on this topic, but here in the US, pill users need to get a prescription from a doctor or pharmacist, and this can pose barriers to access. In 2016, IVIS and a group of experts in the OTC working group partnered with a pharmaceutical company, and we're currently in the process of conducting the research needed to submit an application to the US Food and Drug Administration. During the pandemic, the messaging of the campaign has had to adapt to the new landscape. You can see some of the changes in this image from social media, graphics showing people with masks and language acknowledging how barriers may have increased or intensified during COVID-19. And the barriers have indeed increased. This includes challenges with transportation, nearby clinics shutting down, people's loss of job and health insurance, or loss of privacy, especially among young people. In many cases, this has exposed barriers that people of color and Indigenous people in the US have experienced for a long time, but are now impacting many more people. Another big change for the campaign, including switching to virtual visits for annual visits with lawmakers, which are scheduled for World Contraception Day every year. While the team worried this might result in less productive meetings, they found the opposite. The representatives and their staff were engaged in rich discussion, discussing research findings and policy ideas. They hosted nearly 60 meetings with lawmakers from over 21 states. The virtual visits actually offered opportunity for a more diverse group of people to participate in the advocacy campaign, since it didn't require travel to the US Capitol. In addition, the campaign had to develop new strategies to break into the media landscape, given the coverage of the pandemic and other critical events. Part of this strategy included connecting the importance of an OTC, or over-the-counter pill, with racial justice and hot topics related to the US election, such as healthcare coverage. In terms of research, one of the studies for the FDA application was recruiting when COVID hit last year. In order to keep momentum, they switched to virtual enrollment. The change required a fair amount of work, but it proved to have benefits. They had greater inclusion across the country rather than just select pharmacy sites, and easier recruitment of young people, particularly those age 11 to 14, who are a critical part of the sample. While it wasn't precedented to use virtual enrollment for the FDA trials in the past, COVID-19 likely demonstrated these revised methodologies will work in the future. To conclude, I wanted to highlight a few takeaways. These 2 examples demonstrated the ways that alternative models of care, in this case, I'm talking about accompaniment for abortion and over-the-counter access for birth control pills, are important for increasing access, especially during times of crisis such as the pandemic. The accompaniment model has always centered needs of the individual and meeting them where they are. This philosophy has allowed them to be nimble and adapting in the face of increasing need. While they primarily work in restrictive settings, their response to COVID and the interpersonal quality of care they provide can inform abortion care in a range of settings. In fact, research documenting their work and their expertise has already informed traditional medical organizations who are faced with implementing no-touch telemedicine abortion, which is newly approved by various governments during the pandemic. The Free the Pill campaign has found ways to tie the pandemic to their messaging. There were various silver linings to moving research and advocacy efforts to virtual platforms, and the team suggests that these successes will likely be useful after the pandemic. Over the past year, we've seen how studies can be designed and implemented quickly in response to COVID-19, and how advocacy can incorporate research findings in the changes they make to better serve their communities. I've listed here our guiding principles to research advocacy partnership: respect, mutual accountability, making impact, and shared power. I want to thank you all so much.
Hi, everyone. Thank you so much. That was a really great panel. And I think we just start with a round of questions. Right. And so I think that the first question we'd like to put back to Bridget. And, Bridget, you spoke about this amazing thing called the contraceptive Google map. So could you just talk to us a little about and tell us how this contraceptive Google map was utilized during the pandemic to encourage access and use of contraceptives?
Yes, thank you, Siva. So during the pandemic, most people, most young people were online, and they could not physically move because of close of transport, but at least you could access them online. So we utilized the online platform, and in this case, the map. So we would update on the map, would let them know which clinics are open, what are their working hours, any emergency number that they can call at that particular clinic. And this is how we kept them involved and interested in still accessing their contraceptives despite the pandemic. Thank you.
Yeah. And, Rafia, I think that the work you did around the White Ribbon Alliance, to actually engage citizens and women is really great. So maybe you can share with us what plans you may have to actually scale up these citizen and women engagement mechanisms, such as the listening sessions. And if there are people who are interested, who are listening, in replicating this approach, what advice do you have for them?
Okay, all right. I think, Sarah, in order to answer this question, I'll first start by sharing why listening sessions actually worked. You see, initially we had planned a larger session, with 30 women sitting across 5 to 7 decision makers and talking about their demands and giving their, suggestions. However, because of COVID, obviously, we could not do so. So we had to go for smaller 2 sub-sessions, as I mentioned earlier. Now, interestingly, this turned out to be a blessing in disguise. What happened was this, that in the first sub-session, the small, intimate, all-female environment enabled the women to really talk openly and directly about their problems and also to give their suggestions very confidently. Then, when in the second sub-session, we took that women's spokesperson with us, and that really helped to validate our work. You see, here was a woman from the community talking in her own style, in her own words, and yet she was saying the exact same things that we had brought forward through the findings of our What Women Want campaign. So by combining this evidence with actual voices from the community, this really made the decision makers listen. And, they understood what are the real ground realities there. So basically, what we did was that we actually used the power of women voices, to make that difference. And interestingly, this worked. In a patriarchal society like the way we have in Pakistan, even here, women voices have power and they are able to bring change, which we have demonstrated. And now we are actually taking this measure forward. We are actually replicating this in another province of Pakistan, which is Khyber Pakhtunkhwa. Over there, we are using this platform and this entire medium once again to actually aim for an increase in budget in the family planning budget of the province. So we are very much taking our innovation forward in other provinces as well.
Thank you so much, Rafia. And so while Bridget and Rafia talked about reaching out and engaging some of the more vulnerable groups who fall out of getting access to contraceptive services, both Ida and Sarah talked about self-managed services, right? And so this was so interesting and revelatory, and so it's absolutely essential during these times of COVID-19. So Ida, maybe can you share with us, based on your experience in advocating for self-care during COVID, what were some of the biggest challenges and how did you overcome it? And what would it take to replicate this effort in other places?
Thank you so much for asking that question. The first challenge was to adapt to the COVID context. We had this initiative planned at the very moment where the pandemic hit, so we needed to adjust. We organized meetings. We wanted to organize meetings in person, but we had to change immediately to other platforms. And these virtual platforms, that was a totally new world for us. Second, we had to mobilize the actors who were already active with responding to COVID, especially within the ministry. The problem was that COVID hit exactly the same moment where we wanted to have these meetings. We took the opportunity to talk to the ministry and to use the self-injection. This method existed already, but we used the opportunity to have it now in the stocks. The healthcare facilities, they responded to COVID patients, but so it was very essential for us to be able to use the self-care system. It was also interesting in the other Francophone countries in Africa. It was interesting for us to share this experience with these other countries. So we work together with these countries, but also we wanted to learn from them.
Thank you, Ida. And to Sarah, I think research is so absolutely essential, right? But I think one of the things that is often asked is like, what research strategies have worked best for you to document these advocacy changes over the past year? And how do you avoid overburdening the activists and advocates when carrying out this research?
Yeah, thank you, Siva. I think this balance is really important. And we all know that when we're stretched so thin, particularly in moments of crisis, it can be hard to then take on a partnership where you might have to do extra work. So I spoke a little bit in the presentation about the qualitative methods we used with the accompaniment groups, where we went out and we both documented the experiences of the people seeking abortion services or care and the changes that the accompaniers made. With the Free the Pill campaign, we've really only anecdotally documented what the changes are over the past year. But I also talked about some of the quantitative methods that had to shift to remote recruitment or remote data collection that had previously been in person as a result of the pandemic. But I think broadly, rapid response and rigorous research can actually be successfully conducted between a partnership of advocacy and researchers during a crisis. And this is important because it can inform policy, and it can also show us what we might want to scale up or replicate after the pandemic is over. So a couple of things I think this can look like on the ground. One, we have to adapt quickly. We have to shift resources and staff from research, maybe from one project that was ongoing to a project that's needed at the time. Two, we have to make sure we take into account various stakeholder perspectives. So we don't just want to document one perspective, but we want the people that are accessing the services, the people providing the services, and then other stakeholders who are key in the advocacy work. And then the other thing that I've heard a little bit in some of the other presentations as well is there are barriers, and we all have heard so much about the barriers. So we want to document those, but there are some facilitators that may have happened as a result of the pandemic, maybe changes in policy or other things that have made it easier or different to get contraception or abortion services. And we also want to document those in case we can carry them after the pandemic. So for example, there have been some policies lightened about how people can get contraception in the US for maybe not needing a prescription or not having to go in. And we may want to have those services continue after. So documenting how people felt about that is important. And then the last thing I want to say about the burden is I think one of the things that's important in our research partnerships is recognizing what expertise each group brings to the table. So as researchers, we want to make sure we take on the burden of doing the data collection and fulfilling the logistics of the research, and then leaning on the advocates to know best how to recruit the communities they work with for the research, for example. And making sure that we use community engaged principles so that groups together, the advocates and the researchers, are designing the research questions together and the goals together, so we're sure that it's actually going to be useful in the end.
Thanks, Sarah. And now I thought that we'll go to the questions that are in the Q&A box, right? And I'm going to try to combine 3 questions which are directed to Bridget. From Rodrigue and Josephat and Esther. So Bridget, so basically the first question is about, how do you actually serve the youth? Are you putting youth in touch with providers to reply to youth SRH questions? And how do youth who are not educated, who can have difficulties to access the map and read the information? So that's one set. And the other one is basically about is it really, how can we actually advocate for government at local level to take over such a contraceptive Google Map or a mobile app application, and rather than this being the role of CSOs? So Bridget?
Yes, thank you, Siva. So when it comes to access of the map by young people in societies that cannot access internet, so in the history or the background of this particular innovation, there was the research that was done in Kampala is the one that we concentrated on. So this means that we knew, largely Kampala is the capital city of Uganda. So we knew most young people within Kampala are able to access internet, at least in one way or the other. So those are the young people this innovation is targeting, and any other young person who would be in urban areas. However, we have other platforms that can reach out to the young people who can't access internet. For example, we have community outreaches, we have things like meetings where you involve district leadership. So there are other platforms to reach young people. If I can move on to the other question that talks about how do we get the government interested in this innovation? From our side, our team, the way we are getting them interested is by showing them the purpose and the positives that are coming out from this platform. We keep in touch with them, we keep sharing the data that we collect, we keep sharing how the innovation works. And we hope that by the time we are completing this project, the government will have shown interest and will be willing to even get another partner on board to be able to support this project so that it can continue and this innovation can continue running for the young people. And then when it comes to the health facilities and health providers, whenever we interact with the health facilities, we talk to the health providers and encourage them to have youth friendliness. So that means when they interact with the young people, they're able to make them comfortable, they're able to interact with them in the right way, and they're able to provide for them whatever service that they're looking for. So we encourage youth friendliness, and this is how we encourage the interaction with the health providers to be as smooth as possible. Thank you.
Thank you, Bridget. Our next set of questions goes to Rafia. So I think that the most important one is like, how challenging was this for you to conduct these listening sessions, right? In gathering women's voices and engaging decision makers given the existence of the pandemic? Was there a lockdown in Pakistan? And how did you operate within that context and become successful? And then there's a set of questions about, how did you engage with men in this area? And also, and there's a question about how you feel this intervention kind of fits in with the population policy in Pakistan.
Okay, that's a lot of questions. Okay, let me see if I can answer them. Okay. First of all, with reference to the challenges, yes, there was a lockdown in Pakistan, and it was challenging. Actually, interacting with decision makers wasn't very challenging because, we could use this Zoom platform and we could have all these online meetings. So with them, we were able to interact during the lockdown as well. However, we were unable to do our listening sessions for quite some time. We had to delay them. And I'm sure if you run projects, you would know what a nightmare it can be when you have to delay activities. However, we were able to then start the listening sessions when the lockdown was eased to some extent. And then, as I mentioned, following those protocols, what we did was we divided the sessions into 2 subsessions, and we had a smaller group of women. Initially, we had planned actually only 2 sessions, like obviously with more women, but then as the number of women got less, we had to increase the number of sessions. So we went to around 5 listening sessions. So we ensured that we got the maximum number of women, but we got them in smaller groups. So, you innovate, you think differently, you try to sort things out. So it was challenging, but we worked over it. Okay, engagement of men. Basically, you see this entire project is actually focused on elevating women and their voices. So male engagement wasn't directly a part of it. However, it was very interesting. I mean, one of the demands which came forward from the women was this, that when it comes to family planning, it's very important to raise awareness of men, and even more so to raise awareness of mother-in-laws. So the interesting part is this, that through these like demands which were highlighted, we have been able to take this area to the decision makers, and now engaging men, involving them, like increasing their awareness, and of course sensitizing the mother-in-laws is going to be on the agenda of the government of Sindh in the coming months. And finally, with reference to policy, okay, you see, in Pakistan, population is actually a provincial subject. That basically means that every province has its own policy. Now, Sindh has a population policy, and it came forward in 2016. And this policy is very much geared towards the achievement of targets set by the government of Pakistan under the FP 2020. Now, actually, what we have achieved is this, that we have been able to incorporate this citizen-driven accountability mechanism of listening sessions in PC1. Now, what does that mean? That basically means that now when the government of Sindh moves forward for achieving its targets under FP 2030, it is mandated in a way to conduct these listening sessions and to get data from here in order to implement its family planning program for the next 5 to 10 years. So citizen engagement, women engagement especially, will now be an integral part of the family planning programming in the province of Sindh. So this is the achievement. And that's how we've been able to, in a way, obviously, facilitate the government in achieving its policy objectives by changing the modus operandi, how it should be done, engage women, involve women. That's the thing.
Yeah. Thank you so much, Rafia. So our next question goes to Ida, and I'm not sure if someone wants to translate for her. So in the experience of Senegal, and I think what was outstanding was the ability for you all to make these guidelines, right, for self-managed self-care. So the question coming is, how was the self-care guidelines, which are great, how did you translate that to the user community? So how did you link those guidelines back to the users of FP so that they could use it?
Thank you for the question. For the time being, we're not quite there yet. We're really at the beginning of this work, and we've begun to discuss this with the various stakeholders about this question with the leadership of the Ministry of Health. So we're in a process of developing the guidelines on self-care. But self-care, however, is not something new. There are a number of programs that have already developed self-care strategies. If I take the example of family planning, in Senegal, we already have a scaled-up program on the self-injection. So our role is really to federate all of the stakeholders around self-care strategies under the aegis of a program. So what we're trying to do is make sure that partners are who are interested can promote, or are concerned can promote that self-injection as a self-care strategy. Thank you.
Thank you, Ida. So now we go back to Bridget, because we still have a couple of questions for Bridget. So Bridget, one of the questions that's coming is that under the map for sexual and reproductive health services, they could not find any post-abortion care in any of the health clinics. And is it because none of the health clinics were offering this service, or because it was not included within your project? And secondly, there was a question about, can you describe the data collection process for the contraceptive Google map, and what challenges did you have in accessing the data, facility data?
Yes. Thank you, Siva. So when it comes to post-abortion care, it's not that the facilities do not provide it. They do provide any complication care for any complications that may come out from abortion. However, from our interaction with several of the facilities, they say they prefer to concentrate on the contraceptive use. They prefer to encourage the young people to come and get contraceptives, rather than them ending up in the situation where they have complications with abortion. So that should be able to maybe speak into why it's not among the listed services. However, it can be provided. And then when we talk about the data collection process, so basically it's us moving to the health facilities and finding out from them which contraceptives are available. If the stock is available, how long can it last? And then being able to know when will be the next time that they will be able to receive more stock for that particular contraceptive. So that's the kind of information we pick from the health facilities. And in terms of challenges, we've not really had challenges. It was at the beginning when we were starting this work that we had to really introduce ourselves and be able to gain the trust for them to be able to share with us their information. However, after they realized the importance and the positive outcome of us being able to share with people out there which contraceptives they provide as a facility, they have found no issues with it. And we've also found no challenge with working with the health facilities. Thank you.
Thank you so much, Bridget. And then there is this last question that goes to Rafia. So actually the question is, these women who participated in these listening sessions and all, did these women subscribe to an organized outfit, or were they individual clients of family planning? And if they were individual clients, how will these advocacy and accountability efforts be sustained without the backing of an INGO or any other support?
Okay. First of all, these were women from the community, and they were like individual, FP clients. The important thing is that most of these women, actually almost all of these women, were the ones who had earlier participated in our What Women Want campaign. So in a way, first we went to them, we got their responses about what they wanted with reference to reproductive health. Now we went back to them and we told them, okay, we're doing some work for you. And now we want to know more about family planning and what you want with that. So, and as we keep on working, we'll keep on engaging these women. However, when it comes to sustainability, the best sustainability is one where no NGO, INGO is required. Why? Because the government takes it up. And this is what has happened now. Now, as I mentioned earlier, the government of Sindh is now mandated to undertake listening sessions and to take that data and use that for improving its FP programming in the province. So this is the best sustainability. We don't have to be there. These sessions will continue to happen. Women from all across Sindh will continue to be involved, and the decision-making of related family planning in the province will definitely be guided by their demands and by the identification of gaps by them. So this is the best sustainability, I think.
Yeah. Thank you so much, Rafia. And then we have one more question coming for Ida. So this question is about, is access to FP self-care services included in the national and community health insurance schemes? And that this is important because then it can eliminate any economic barriers amongst vulnerable groups such as disabled persons.
If you're talking about private insurance or public insurance, it's not something that's totally covered. So that could be a strategic objective for advocacy that we can include in our guide on healthcare. But I think that in Senegal, that there's family planning method approaches that are taken into account in public policy. If I can give you an example, the use of these services costs about 300 francs in local currency for a 3-month protection. So it's fairly accessible, especially since it's subsidized by the state or by organizations that work in this field.
Yeah. So I think as just a couple of last questions to kind of wrap up the session, I just wanted to ask Sarah, because you talked about two very interesting initiatives, which is both the self-managed abortion as well as free the pill. So how are you creating allies? Because clearly, creating allies with policymakers and others to advancing the issues is a really key component, right? And have you ever found any of these unexpected allies who are important in your advocacy?
Yeah, as you mentioned, I spoke about two interventions that were self-care or self-care-ish, both people taking medications for abortion and getting the pill on their own without a prescription. And interestingly, I think one of the key allies in both cases has been clinic-based providers. And that might be unexpected or might not be, but I think the ability to build partnership across both the formal sector and the informal sector of care is critical. For one, we have, I mentioned in the presentation, there are aspects of the quality of care that the accompaniers provide, really like patient-focused care that can be taken and learned from in the formal sector. So some of the qualities of that care can inform ways that we provide in the formal sector. And then similarly, some international NGOs have asked for information on how they can better support people to get self-managed abortion. So these are providers that offer medical and surgical abortion in their facilities, but they realize that self-care is starting to become more and more popular in different areas, whether it's because people need to do it or they want to do it. And so these international NGOs are seeking out ways that they can support people to get the abortions in any way that they want to. So I think that, the connection between the formal sector and the informal sector has been critical in terms of building allies.
Right. And maybe I can put a last question to Bridget, so looking to the future, what do you think is an important consideration to ensure family planning continuity in the year ahead?
Yes, so in the context of my country, Uganda, for family planning to continue and move forward, I would encourage all of us to work together, all stakeholders to be involved. This includes the parents, this includes the religious institutions, this includes the cultural institutions, because those are the institutions usually that limit young people from accessing contraceptives. And in this case, if we all work together, I believe family planning will progress and will be very successful in my country, Uganda.
Thank you so much, Bridget. And, thank you to all of these amazing panelists. And although I started at the beginning thinking I was very wary of what challenges COVID poses to us and how that could hamper our advocacy and holding governments accountable to SRHR commitments, it is really great to see, all of the innovations that are happening in service provision, citizen engagement and women engagement and youth engagement, as well as putting power into the hands of both young people and women in order to make these decisions for themselves. And with that, I would really like to thank all of you for spending such valuable time listening to us, as well as learning and sharing and asking these such interesting conversations, So thank you so much for joining us today.
power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies are